أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون وما يكذبك بعد بالدين أليس الله بأحكم الحاكمين صدق الله العظيم. Sir, over to you.
जज़ाकल्ला जी। आज हमारा जो
Bismillahirrahmanirrahim.
वेबिनार है वो डॉक्टर
Assalamu
आमिर
alaikum, everyone.
हमारे एसोसिएट
Ladies and
प्रोफेसर
gentlemen,
हैं। आमिर साहब
my
हमारे
name is
एसोसिएट प्रोफेसर
Dr.
हैं
Aamir
विमेन
Khan.
मेडिकल कॉलेज में। तो उनका टॉपिक है कैटरेक्ट, इट्स टाइप्स, इट्स प्रिवेंशन एंड मैनेजमेंट। ओवर टू यू डॉक्टर आमिर।
Assalamu alaikum, everyone. My name is Dr. Muhammad Aamir Khan. I'm Associate Professor in Women Medical College. Uh, Today, we are going to discuss a few things about cataract. Most of you will be aware of cataract, but I will be discussing a few things in detail. As you all know that cataracts are a major cause of treatable blindness all over the world. More so in Pakistan as well. Pakistan, the age-related cataract is responsible for about 48% of world blindness, and in Pakistan it's about 6%. So, which represents about overall in the whole world, it represents about 18 million people, which is a very alarming and a huge percentage. So in both developed and underdeveloped countries, cataracts are a major cause of low vision. And, as you can see in this slide, that major cause of treatable blindness is cataracts, and after that the glaucoma and other causes comes. So let's see what cataract is. Basically, cataract is a word that came from uh, Greek language and as well as Latin, which literally means waterfall. So the people thought that it looked like a waterfall, so they named it as cataract. So cataract is nothing like nothing actually which flows, but there is it looks like a waterfall. So the basic thing is that there is decreased vision. So let's see why there is decreased vision. So to learn about that, we should be able to see where the problem is. Basically, the problem is in a part of the eye which is called lens. Normally, it is very transparent and very clear structure, but when there is cataract formation, there is blurring of vision and there is decreased vision. So this is the anatomy of the lens, and it consists of a capsule and a cortex and a nucleus. The nucleus is the central part, and cortex is the peripheral part, whereas the capsule is the part which is a very thin membrane that covers the whole lens. So anywhere under the capsule or in the cortex or in the nucleus, if there is hydration of the lens proteins, the cataract results. So what happens here is that as you can see in the normal lens is clear, whereas the lens where there is cataract, it is clouded. You can see in the picture on the right side, there is a white reflex in the pupil. So that is how the mature cataract looks like. So the cataract can be, most commonly it is because of age. As the person grows older and older, the lens material or the lens parts, nucleus, cortex, they become more and more uh, cataractous, you can say, so to speak, or they become more and more blurred. So age is the most common cause, and then come the other diseases like diabetes or inflammation of the inflammation within the eye or other ocular surgery. They can lead to cataract. Or if the patient has been using medications, topical or systemic, like steroids, most common cause of pharmacological cataract formation is steroids. They can be systemic, can be topical. And similarly, the examples of other medications the patient might be using are psychotropic drugs like phenothiazines, carbamazepine, or if the patient is having any cardiac conditions like arrhythmias. So amiodarone is a drug that can be used in arrhythmias, anti-arrhythmic drugs. So they can cause cataract. Similarly, gold, allopurinol, these drugs can cause cataract. Other causes of cataract formation can be trauma, can be blunt trauma, or can be penetrating trauma. And then ionizing radiations like X-rays or UV light, UV rays in the sunlight can also lead to cataract formation. Similarly, ultra red radiations, and they can lead to cataract formation, or if the patient has any electric shock, that can also lead to cataract formation. Then we have congenital cataracts. We might find cataracts in the children who have cataract because of a part of a syndrome, like Down syndrome. We might have seen, most of the people have seen Down syndrome, which is very common. And other syndromes like Turner syndrome or Loeys syndrome, etc. Then congenital cataract can result from metabolic derangement like galactosemia. We can have abnormal galactose metabolism and typical oil droplet cataract is formed. Then you can have inherited abnormality like myotonic dystrophy or Marfan syndrome or infections with Bacillus staph infections, Toxoplasma rubra, cytomegalo, herpes virus. Then there is a high where the active length of the eyeball can be more than normal. If it is very high, then it can also lead to high myopia. Can lead to cataract. So how is the cataract formed? That is, to make it simple, we have just the opacification of this lens takes place through hydration of the lens proteins, because basically the lens is made up of proteins. So proteins are crystallines, and crystallines normally they are very clear, but when there is hydration of the lens proteins, then the lens becomes cataractous, or it becomes blurred. So one of them is hydration, the second is denaturation of the lens proteins, and the third is slow sclerosis, which occurs due to age. So the basic mechanism is that the lens proteins, they become opacified. So when they are opacified, there is loss of transparency of the lens and the cataract formation occurs. So now we have ascertained that there is cataract. Now we got to classify the cataract And that is classified on the basis of its morphology or its anatomy or the age of onset or its maturity or the cause from where it arose. So we can classify it according to that it is acquired or it was congenital. So acquired cataract can be age related, which is the most common cause, and the metabolic conditions like diabetes, radiation or electric cataract, as I already told you, traumatic cataract, toxic because of drugs, secondary cataract because of any inflammatory conditions. Age of onset can be congenital, infantile, juvenile, presenile, senile. So most common is the senile, and you can also have congenital. So these are the pictures taken. You can see the cataract in the people, this white reflex, and the this type of cataract in children it can also mimic other conditions which are more dangerous, like retinoblastoma is an eye tumor, or other conditions like persistent primary hypoplastic vitreous. So these are the conditions you can see by bilateral cataracts in the child in the right side. So age-related cataract can be morphologically classified as according to where it is present under the capsule or the anterior to the capsule, or a particle cataract or nuclear, supranuclear, polar. So as you might remember that picture that I showed you earlier of the lens anatomy. So if the lens is the cataract is classified according to where the cataract is present, according to the anatomy. So it can be capsular, subcapsular, cortical, nuclear, etc. So nuclear cataract is it's a cataract which is normally you can see it's from the nucleus, so it's nuclear cataract, which is the central part of the lens. So if the lens, if the cataract involves the central part of the lens, that is called nuclear cataract. And this is more likely to cause visual symptoms because it's present in the center, and it's obstructing the visual axis. So if we compare it with the cortical cataract, so the nuclear cataract is more likely to cause visual problems. So this is cortical cataract. Cortical cataract is obviously in the periphery, and if the center is clear, so the cortical cataract might not be be advised to remove it. So these are the two cataracts, nuclear and cortical cataract. They are compared here. Then comes the capsular cataract, which can be under the capsule, anteriorly or posteriorly. This is the normal lens. Then there is immature lens, and mature lens. Maturity can be determined on the basis of red reflex. There is a instrument called direct fundoscope, and we shine light through the fundoscope. We see through the fundoscope, and we shine the light on the pupil of the eye. And if we can't see any red reflex, then that is where we call the cataract as mature cataract. And if we can see even a little bit of red reflex, then we call the cataract as immature cataract. Similarly, when the mature cataract, it becomes more and more hardened, and the capsule on it becomes more wrinkled, and there is absorption of fluid from within the lens capsule, the lens capsule becomes wrinkled and hardened and brittle. So that's when we call it hypermature cataract. So these are the types of different types of cataract. This was on the this is a mature cataract. So this is hypermature cataract where the anterior capsule is shrunken and wrinkled. This is a type of hypermature cataract, which is called Morgagni type, where the cortex undergoes autolytic liquefaction and absorption of the cortex from underneath the nucleus. So the nucleus loses support from the lower side, from the inferior side, and then it settles to the bottom. That is called Morgagni cataract. So clinical manifestations are that the will patient will present to us, to the eye doctor, with the complaints of blurred vision or photophobia, that the patient says that I feel my eyes are very sensitive to light. I can't bear the light. Especially the problem is with nighttime driving. So the lights coming from front, they are very troublesome, and patient has a scattering of light. And there are distorted images. Patient might have diplopia, double vision, and these are the problems that the patient might have. And also, the patient has problems with color perception. So this is how, on the right side, a patient with cataract will have a vision like this. On the left, one has a clear vision, and on the right side there is blurred vision. So now, this is the example of a cleared view, nighttime driving. The people who are used to driving at night might have a good idea of what it is like. And so when there is cataract, what we have to do is that now the patient, there is no medical treatment for that, to remove the cataract. There is only one way to remove it, and that is through surgery. So before surgery, we have to evaluate the patient. We have to do the visual acuity test. We have to collect history. In history, we find out about the patient's previous history, any surgeries, any medication he's using. He has any systemic conditions like diabetes, hypertension, similar conditions like asthma as well. So we record the visual acuity, we do the dilated eye examination. Dilated eye examination is needed to see if there is any problem in the fundus, in the retina, which is the sensitive part, and which is the area where the image is formed. So if a patient's, if the surgeon has performed a very beautiful surgery of cataract, to remove the cataract and put intraocular lens in it, and operatively patient has no vision or the same vision. Vision hasn't improved. Then there is a question from the patient that why did you, from the surgeon, that why did you perform surgery when I wasn't expected to see. So patient is expected to have good vision post-operatively. We as surgeons always have to do this dilated eye examination to see whether the retina is fine enough, or at least we can comment on it, or we can explain the prognosis to the patient that if you are going to have good vision or not. So this is the importance of dilated eye examination. Then we can do tonometry, is the checking the pressure of the eye, which is also very important. Then there is one thing that we also do is that that is called biometry. I'm sorry I didn't mention it here, but biometry is a procedure that where we uh, calculate the number or the power of the lens, intraocular lens, the artificial lens that we are going to implant in the eye. So that is important. Then we go on to the surgical removal. For surgical removal, we have the newest technique to remove cataract is through phacoemulsification method. The extracapsular cataract extraction and intracapsular cataract extraction, they were the older methods. Extracapsular is still being used in Pakistan in fewer and fewer areas now because phacoemulsification is being used more and more. More the newer surgeons that are coming forward now, they are well equipped and well trained in phacoemulsification. So the extracapsular method is now being less and less in vogue, and intracapsular cataract extraction is almost obsolete now, except that if there is an indication, like if there is subluxated lens or some other conditions. So phacoemulsification is a procedure where we make a small incision in the cornea and go and through a probe we remove the nucleus, which is the hard part, and through this phaco probe there is a phaco tip in it, and in that there is a crystal that imparts ultrasound rays at a high frequency, and then that rays, they break the nucleus, make trenches in the nucleus, break the nucleus into smaller pieces, and then through the same port, through the same phacotip, these parts, these pieces are removed, and the nucleus is the hard part. So when it is when we have removed that, then there remains only the cortex, which can be removed through other instruments. So we don't need any bigger incision. So when cortex and the nucleus are removed, the only thing that remains of the nucleus is the capsule. So capsule is the area is the part where the intraocular lens will be implanted. So through the same small incision, we insert the foldable lens through that into the capsule, and voila, the procedure is complete. So we don't have to put any sutures post-operatively, or even during the surgery, we don't apply any local anesthesia most of the times. We only use topical anesthesia, which means that we put drops on the cornea and the surgery is proceeded. So you don't need any local anesthesia or even general anesthesia. Only topical anesthesia is applied. So that makes very easy for the patient, and post-operatively patient has good eye. So this is the picture of intraocular lens. This is a foldable lens which can be folded, because in this condition, in this state, it cannot be entered through the small incision. So it has to be folded and loaded in an injector, and through that small incision, the injector injects this lens into the capsule, and then it settles down in the capsular bag, and the patient has good vision post-operatively. This is the picture of a nucleus that was being extracted through a cryoprobe, which was intracapsular cataract extraction. It's not used nowadays. So post-operatively, we give steroids, antibiotic drops, and regarding the prevention of the cataract, it's known that smoking, alcohol consumption, or ultraviolet rays in the sunlight, they are known to cause cataract. So using sunglasses which have ultraviolet rays blockage, and or prevention, or quitting smoking or alcohol, we can prevent cataract formation. Similarly, using these vegetables, leafy vegetables, is also helps in preventing cataract, because it has antioxidants. So using antioxidants can also help. But these measures are temporizing measures that you can't for sure 100% you say that by adopting these measures you are going to prevent cataract, because cataract with age is it's going to be there. You can't prevent it 100%, but we can always take these measures to decrease the percentage of cataract formation. So we can have these complications of cataract surgery, but they are now very, very, very less in number. They're very rare now, especially in the Western world, but even in Pakistan, it's very rare now, because the antiseptic and sterilization measures are very have advanced now. So the most dreadful or dreaded complication of cataract surgery is acute post-operative endophthalmitis. So as a surgeon, we are very wary of this complication. So, and during the surgery, suprachoroidal hemorrhage can occur, which is also a very dreadful condition or a complication which can happen during the surgery, and it's it literally means that the patient has lost the eye. In endophthalmitis, there are chances that you can salvage the eye, but in suprachoroidal hemorrhage, there is profuse bleeding from the eye, and all the layers of the eye, and the retina and the choroid, they are expelled out. So there is no chance of salvaging the eye. So it's a very dreadful complication. So other complications that can happen post-operatively years after that, after the surgery, can be retinal detachment, cystoid macular edema, glaucoma, or posterior capsular opacification. So that was all about cataract. I hope you learned a few new things from it. I'm sure most of you know about these about the cataract and its complications, or its most of the procedures and the types and everything, but still there are a few things that we always miss out on. So this was about cataract. If you have any questions, please you can ask. Can
Hello, we can't hear you. Wadeed? वदीद आवाज नहीं आ रही है.
अस्सलाम वालेकुम मैम, कैन यू स्पीक अगेन? आपकी आवाज़ बहुत आहिस्ता आ रही है।
चैट का प्रश्न से जवाब ये क्या है? आपने लिखा है कुछ?
डॉक्टर साहब आपकी आवाज नहीं आ रही.
जी मैम, सेशन इज क्लोज नाउ.
ओके ओके, थैंक यू आमिर, दैट वाज अ लवली सेशन. हमेशा से मैं सोचती थी कि आखिर कैटरेक्ट की वजूहात क्या हैं. तो आप ये बताएं, हर एक घर में माइक्रोवेव होता है और अक्सर बच्चे माइक्रोवेव के सामने बैठ के 1 मिनट हो गया है, कुछ सेकंड ऊपर हो गए, देख रहे होते हैं. डज इट हार्म द आई?
माइक्रोवेव microwave exposure can lead to cataract formation, but not on a very small scale, like you're heating something in your kitchen, or it can happen due to prolonged exposure, not due to very short exposures.
तो मुझे लगता है उससे ज़्यादा तो ये सनलाइट की एक्सपोजर वुड हार्म अस. हाँ, जो हम रोज़ धूप में बाहर निकलते हैं विदाउट सन ग्लासेस.
Ji, as I mentioned in my talk, that ultraviolet exposure can lead to cataract formation. So you always should wear sunglasses which have UV protection.
Okay, okay, great, Amir. That was a lovely talk that you gave. And
Thank
I'm sorry
you.
for the less attendance. Less attendance इसलिए हो गई, रूटीन में हमारा ये वेबिनार संडे पे है. और हम पाकिस्तानी
Ji.
हमेशा ये समझते हैं कि जी संडे को होगा, तो सैटरडे को probably एंट्री नहीं हुई. But now your lecture is saved with us. We'll upload it and सब students इसको सुनते रहेंगे. सिर्फ
जी
हमारे
मैम,
कॉलेज में
जब
नहीं, ऑल
जब
ओवर
आप लोग
पाकिस्तान.
अपलोड करेंगे या दूसरे लोग सुनेंगे तो लेट मी नो एंड आई विल बी अवेलेबल फॉर आंसरिंग एनी क्वेश्चंस.
Okay, with that we will give your email address so they can address you. ठीक है?
जी प्लीज.
Okay, thank you so very
थैंक यू.
much. Thank you,
थैंक
Wadeed.
यू.
And thank you, Zainab is here. Zainab, आपने कोई comments देने हैं? क्योंकि Zainab भी ophthalmologist है.
अस्सलाम
Zainab,
वालेकुम. नो मैम, सर ने माशाल्लाह सब बड़ा अच्छा कवर कर लिया सब कुछ.
सर ने तो बड़ा अच्छा cover किया हुआ है. And it was really,
जी
really
जी.
pleasure listening to him. तो अल्लाह पाक सबको
थैंक यू
प्रोफेशनली बहुत
फॉर
तरक्कियाँ
अटेंडिंग
दे,
द लेक्चर.
हाथ में आपके शफा दे. जी आमिर.
मैं डॉक्टर जैनब से बात कर रहा था. मैं उनका शुक्रिया अदा कर रहा हूँ कि थैंक यू फॉर अटेंडिंग द लेक्चर.
और
Okay,
सर,
thank you so much. Amir, it was a pleasure having you here and I
थैंक
wish
यू.
you could have done it on a Sunday, तो बहुत ज़्यादा attendance होती. खैर anyway, एक तो 14th August भी आ
जी
गया,
मैम.
long weekend भी आ गया. तो this is saved with us and it will be here always with us and we'll upload it. So thank you, and thank you Saima for being here. Thank you Wadeed. और Amir, Allah bless you.
थैंक यू.
Have a nice weekend. Allah Hafiz.
थैंक यू मैम, अल्लाह हाफिज़.